Hello everyone, in this video we are going to study about dysmenorrhea and other disorders of menstrual cycle. Definition: dysmenorrhea literally means painful menstruation. So here the women who gets her menses every month, they are going to be painful. The painful menses are nothing but dysmenorrhea. But a more realistic and a practical definition includes the cases of painful menstruation of sufficient magnitude so as to incapacitate the day-to-day activities. Here they are saying if you want to give a more realistic or a more practical definition, you can say that the painful menstruation is so severe that they are hampering or incapacitating the person to perform her day-to-day activities. She is not able to perform her day-to-day activities. When the pain is so severe, then it is termed as dysmenorrhea. Types: there are two types, primary dysmenorrhea and secondary dysmenorrhea. Two types, primary, secondary. First, we'll be dealing about primary dysmenorrhea. Primary dysmenorrhea is also known as spasmodic dysmenorrhea. The primary dysmenorrhea is the one where there is no identifiable pelvic pathology, which means there is no abnormality detected. The woman, she's having dysmenorrhea, the menses are very painful. She goes to a doctor. The doctor asked her to perform the USG or the scan. She gets it done. In her scan, no abnormality is detected. Everything is perfect. In spite of that, she's having pain. Then this is known as primary dysmenorrhea, when there is no abnormality, yet the person is having pain. The primary dysmenorrhea is the one where there is no identifiable pelvic pathology. Incidence: pathology is the abnormality. No abnormality detected. Incidence: the incidence of primary dysmenorrhea of sufficient magnitude with incapacitation is about 15 to 20%. We read that in primary dysmenorrhea, the pain is so severe that it is incapacitating the person to perform her day-to-day activities, and this type is only about 15 to 20%. With the advent of oral contraceptives and non-steroidal anti-inflammatory drugs, there is a marked relief of the symptoms. So, for the painful dysmenorrhea, there was a discovery of oral contraceptives and the NSAIDs were discovered, which were brought into practice, which were used, and they brought in a lot of relief in the patient. With the advent of the oral contraceptives and NSAID gave relief to the symptoms. What are the causes of the pain? Now, no abnormality detected. You have to have that on your brain, that there is no abnormality detected in primary dysmenorrhea. No identifiable pelvic pathology. In spite of it, what might be the cause for the pain? It is mostly confined to the adolescents. You see, the primary dysmenorrhea, it usually occurs in the adolescents. Adolescents are the people who are aged from 18 to 24 years. It is almost always confined to ovulatory cycles. You see, every month ovulatory cycles happen. The pain almost confined when the pain comes during the ovulatory cycle. Almost always confined. It is almost around the ovulatory cycle only. The pain is usually cured following pregnancy and vaginal delivery. So, after the pregnancy or the vaginal delivery, the pain gets usually cured. The pain is related to dysrhythmic uterine contractions and uterine hypoxia. You see here, two things they have told. Following the pregnancy or vaginal delivery, the pain gets cured. Why does it get cured? It is because there is a damage to the sensory neurons which cannot regenerate again. During the delivery, there is damage to the neurons. They do not regenerate, so the pain stops. Second thing, dysrhythmic uterine contractions. You see, there is a certain rhythm to be followed when there is dysrhythmic uterine contractions and uterine hypoxia. Hypoxia, what is hypoxia? The oxygen saturation. When the oxygen supply is reduced, then it is uterine hypoxia. When the oxygen supply, that is via the blood, when the oxygen supply to the uterus is reduced, then there might be pain. So the pain is because of dysrhythmic uterine contractions and uterine hypoxia. No abnormality because of those dysrhythmic uterine contractions, and also because of the uterine hypoxia, the person feels pain. Along with that, we are going to deal with a few causes. Psychosomatic factors. Psychosomatic factors of tension and anxiety during adolescence lower the pain threshold. You see guys, here during the adolescence, that is young age, that is 18 to 24, the girl will have a lot of tension and anxiety. Anxiety is being worried about. She is worried about her disease. It is lowering her capacity or ability to endure the pain. She cannot bear her pain. It is lowering the pain threshold. This is the psychosomatic factor. Now we come to the abnormal anatomical and functional aspect of myometrium. What is happening in the myometrium? There is an abnormal anatomical and functional aspect of myometrium. There is some abnormality happening in the myometrium. Uterine myometrial hyperactivity has been observed in cases with primary dysmenorrhea. Guys, you see, there was no pelvic pathology was not detected, but in the myometrium, it is functionally what is happening. There is uterine myometrial hyperactivity. This is not a pathology. This is not a pathological change. So no pelvic pathology detected, but this thing you have to remember: the uterine myometrial hyperactivity has been observed in cases with primary dysmenorrhea. You see the myometrium here, endometrium, myometrium, uterine myometrial hyperactivity. So the myometrium is undergoing hyperactivity. It is becoming hyperactive. Because of that, this has been observed. The outer myometrium, you see the outer in the picture, there is an outer myometrium, and the subendometrial myometrium are found to be different structurally and functionally. You can see the subendometrial myometrium, the myometrium which is near the endometrium, the subendometrial myometrium, and the normal myometrium, the outer one as well as the subendometrial myometrium, both have different function and they have different structure. The subendometrial layer of the myometrium is known as junctional zone. So you see the subendometrial layer, this is the endometrium, the layer of the endometrium, the subendometrial layer of the myometrium, this is known as junctional zone. See guys, this is the endometrium, the subendometrial layer. But which layer of what does it belong to? It belongs to the myometrium. You can see in the picture here, the subendometrial myometrium layer is also known as junctional zone. In women with the dysmenorrhea, significant changes are seen in the junctional zone. You can see in the junctional zone, there are significant changes occurring in the women suffering with primary dysmenorrhea. What are the changes? They are irregular thickening. You see the junctional zone, there is irregular thickening and hyperplasia of smooth muscles. Hyperplasia is nothing but increase in the number of cells. The cells are going to multiply and increase in the number of cells. Hyperplasia of smooth muscles. You see here irregular thickening, hyperplasia of smooth muscles, and less vascularity. We saw there was uterine hypoxia, no blood supply, less vascularity is there. This is known as junctional zone hyperplasia. Dysperistalsis and hyperactivity of the uterine junctional zone. Dysperistalsis and hyperactivity of the uterine junctional zone are the important mechanisms of primary dysmenorrhea. From this slide, what you have learnt is, where is the junctional zone located? You see that you have to write that the endometrium and the subendometrial layer both are different structurally and functionally, and the junctional zone, the subendometrial layer of the myometrium, is also known as the junctional zone. There are significant changes happening in the junctional zone. There are 3 changes. One is irregular thickening happening, second hyperplasia of smooth muscles, and less vascularity. Then In conclusion, you have to write the dysperistalsis and the hyperactivity of the uterine junctional zone. These two are the important mechanisms of primary dysmenorrhea. Imbalance in the autonomic nervous control of uterine muscles. You see, the nerves also, there is an imbalance. Imbalance is found in the autonomic nervous control of uterine muscles. What is happening to the nerves of the uterine muscles? There is overactivity of the sympathetic nerves. Like how there was hyperplasia of the smooth muscles, here the nerves also there is overactivity, hyperactivity of the sympathetic nerves. Because of the hyperactivity, there is hypertonicity of the circular muscles. Once the nerve supply, the overactivity is there, obviously what it is supplying, the muscle, there will also be an increase in the tone. There is hypertonicity of circular muscles. So in turn there will be dysrhythmic peristalsis. More contractions will happen here. Once there is overactivity of sympathetic nerves, there will be hypertonicity of the circular fibers. As a result, dysrhythmic uterine contractions happen. Because of the more overactivity of the nerves, more contractions, more pain. The relief of the pain following dilatation of cervix or following the vaginal delivery may be explained by the damage of adrenergic neurons which fail to regenerate. We have already discussed this. Following the vaginal delivery, what happens, or during the dilatation of the cervix, the adrenergic neurons where there was hyperactivity, they get damaged. Once the neurons are damaged, then no hypertonicity, then no pain. Role of prostaglandins. In ovulatory cycles, under the action of progesterone, prostaglandins, prostaglandin factor 2 alpha, prostaglandin E2, two things, PGF2 alpha and PGE2 are synthesized from the secretory endometrium. See guys, you see the endometrial lining here, secretory endometrium. Under the action of the progesterone, what happens? There is corpus luteum secreted. The corpus luteum produces progesterone. Under the action of progesterone, what are produced? Prostaglandins are produced. What are the two things? Prostaglandins, prostaglandin F2 alpha and prostaglandin E2, they are synthesized by the secretory endometrium. Once these prostaglandins have been synthesized, either due to the increased production of prostaglandin or increased sensitivity of the myometrium, you see the secretory endometrium, or the increased sensitivity of the myometrium. Now you see the outer layer myometrium here, increased sensitivity of the myometrium to the normal production of prostaglandins, there is increased myometrial contractions. Two things can happen. Either there may be increased production of prostaglandin, one thing, or second, the myometrium, they can become more sensitive to the prostaglandin. The production might be normal, but the sensitivity of the myometrium is increased here, which lead to myometrial contractions and pain. Hope this is clear. Under the action of progesterone, prostaglandin F2 alpha and PGE2 is released. Then these two are released from the secretory endometrium. Two things happen. Either there is increased production of prostaglandin or the myometrium is becoming sensitive to the normal production of the prostaglandin. Then as a result, there will be myometrial contractions. Role of vasopressin. There is increased vasopressin release during menstruation in women with primary dysmenorrhea. So women who are suffering with primary dysmenorrhea, there is increased vasopressin release, especially during the menstruation. Vasopressin increases the prostaglandin synthesis and also increases myometrial activity directly. What does the vasopressins do? First, they will increase the prostaglandin synthesis. In turn, again, it can lead to muscle contractions, uterine muscle contractions. They can also act directly on the myometrial activity and they can increase the myometrial activity. They act on the myometrium and they are going to increase the myometrial activity. It causes uterine hyperactivity and dysrhythmic uterine contractions. Again, the same thing here. Uterine hyperactivity happens and dysrhythmic contractions are seen, which result in ischemia and hypoxia and pain. Because of the dysrhythmic contractions, there is less vascularity, hyperplasia happens, so ischemia and hypoxia is seen. Ischemia is the reduced blood flow, hypoxia is the reduced oxygen flow, oxygen supplied to the uterus, and as a result there will be pain. Then comes endothelins. We saw the role of vasopressins. Now endothelins. Endothelins causes myometrial smooth muscle contractions. Again, the endothelins are also doing the same function. They are causing the myometrial smooth muscle contractions, especially in the endometrial junctional zone called the junctional zone, the endometrial junctional zone, JZ. Endothelins in the endometrium can induce dysperistalsis and hyperactivity. Again guys, same thing you have to write in the endothelins. They are inducing the dysperistalsis and hyperactivity of the smooth muscles. Platelet activating factor, let's see what it does in the role of causing the pain. Platelet activating factor is also associated with the cause of dysmenorrhea as its concentration is found high. You see, people suffering with primary dysmenorrhea, the platelet activating factor is found high in them. Leukotrienes and platelet activating factors are vasoconstrictors and they stimulate myometrial contractions. You see, vasoconstrictors. So, this platelet activating factors and leukotrienes are going to contract. They are going to cause the constriction of the blood vessels. They are vasoconstrictors and as a result they are going to stimulate the myometrial contractions. Now we are going to see in a flowchart possible causes of pain are under the action of progesterone. What is released? PGF2 alpha. You can also write PGE2. There is synthesis and release of PGF2 alpha and PGE2, and also there is a release of endothelin, leukotrienes, PAF. All these, what do? They increase the myometrial contractions. Also they act upon the junctional zone. They also produce dysrhythmia. Along with that, there is reduced blood flow, myometrial angina. You see, myometrial pain is there, angina, since because of the reduced blood flow, hypoxia, ischemia and myometrial angina resulting in pain. Here also the endothelins, leukotrienes, platelet activating factors, prostaglandins, all what do? They increase the myometrial contractions in the junctional zone along with the dysrhythmia and they lead to pain. Patient profile. Primary dysmenorrhea is predominantly confined to the adolescent girls. We saw the adolescent girls who are 18 to 24 years of age, the primary dysmenorrhea is confined to them. It is usually appears within 2 years of menarche. When does it appear? Within 2 years of menarche. Menarche is the first menstruation. If a girl attains, for example, we take a girl attains her menses, her menarche at 12 years of age. The primary dysmenorrhea is going to appear within 2 years of her menarche. The mother or her sister may be dysmenorrheic. So, that is familial inheritance can also be found. Either her mother or the sister might be dysmenorrheic. She also might be suffering from dysmenorrhea, that is painful menstruation. It is more common amongst girls from affluent society. You see the girl here, adolescent girl suffering with primary dysmenorrhea. The clinical features, the pain begins a few hours before or just with the onset of menstruation. Now you see the clinical features here. When is the pain starting? We saw it is confined to the ovulatory cycles. We have already read it is confined to the ovulatory cycles. So the pain is going to start few hours before or just with the onset of menstruation. During the ovulatory cycle, just before the onset of menses or just a few hours before the menses it is going to start. The severity of the pain usually lasts for few hours. How long does the pain last? It may last for few hours. It may extend to 24 hours but seldom persist beyond 48 hours. So they are saying the pain, it will last for few hours. it may extend to 24 hours. At rare conditions, seldomly, rarely, it may extend to 48 hours. The pain is spasmodic. So we know primary dysmenorrhea, the synonym, other name is also spasmodic dysmenorrhea. So the pain also is going to be spasmodic. The pain is spasmodic and it is confined to the lower abdomen. You see the girl here, the pain it is spasmodic and it is confined to the lower abdomen. It may radiate to the back and medial aspect of the thigh. From the lower abdomen, it may radiate to the back and also to the inner side, that is medial aspect of the thighs. Systemic discomforts like nausea, vomiting, fatigue, that is tiredness, diarrhea, headache, and tachycardia may be associated. So you see here, the systemic discomforts are also found in primary dysmenorrhea, like nausea, vomiting, fatigue, diarrhea, headache, and tachycardia are also associated. It may be accompanied by vasomotor changes causing pallor, cold sweats, and occasional fainting. Even the vasomotor changes are seen in them, that is pallor, cold sweats, and occasional fainting. Pallor, sweats are going to be cold, and fainting might also be seen. Rarely syncope. Syncope is nothing but unconsciousness, fainting. Rarely syncope and collapse in severe cases may be associated. Abdominal or pelvic examination does not reveal any abnormal findings. We know in primary dysmenorrhea, no abnormality is detected. So when you do the abdominal or pelvic examination, you cannot find any abnormal findings. For detection of any pelvic abnormalities, ultrasound is very useful and as it is not invasive. So to detect the pelvic abnormality, ultrasound is done. Management of primary dysmenorrhea. Now, an adolescent girl comes to your clinic with primary dysmenorrhea. How are you going to manage the case? Management protocol of primary dysmenorrhea. First, assurance. You need to give assurance to the women, to the girl, not to be anxious, not to worry, since there is going to be psychomotor factors of anxiety and worry will be found in them. You have to ask them not to worry. Assurance should be given. Analgesics and antispasmodic drugs should be given. To empty the bowel, you have to encourage the patient to empty the bowel. Encourage the normal activities. We saw in primary dysmenorrhea what happens? They are incapacitating her day-to-day activities. So you need to assist the patient, give assurance. You have to encourage her to perform the day-to-day activities. If the assurance, the analgesics and the encouragement, everything fails, then two things. One, if the patient wants to conceive. One, if the patient doesn't want to conceive. In the first thing they are saying, no contradiction for prostaglandin synthetase inhibitors, presence of contradiction of pill, patient wanting pregnancy. What does it mean here? Patient wants pregnancy. So the woman wants to conceive. If the woman wants to conceive, you are not supposed to prescribe a pill. Presence of contraindication for pill. Pill should not be given. But there is no contraindication for prostaglandin synthetase inhibitors. You can give prostaglandin synthetase inhibitors, but you are not supposed to give her pill. If the patient wants pregnancy, no pill. No pill, pregnancy, no pill. Now here, no contraindication of pills, wanting contraception, presence of contraindications of prostaglandin synthetase inhibitors. If the patient wants contraception, that is she doesn't want to conceive, then you can give her pills. There is no contraindication for pills, which means you can give pills in contraception. When she doesn't want to conceive, give her pills, not an issue, but you are not supposed to give prostaglandin synthetase inhibitors. Prostaglandin synthetase inhibitors, PSI, should be given for 3 to 6 cycles in patients wanting pregnancy, and oral contraceptive pills for 3 to 6 cycles again should be given in patients wanting contraception. When both the things fail, then there might be some mistake in the diagnosis. So again the patient must be sent for the USG or laparoscopy to exclude the pelvic pathology Example, endometriosis. So there might be a mistake. The secondary dysmenorrhea might be mistaken as a primary dysmenorrhea. So you should ask the patient to get her USG or laparoscopy done to identify the pathology inside. Then next, dilatation of the cervix, that also can solve the problem. Laparoscopy, uterine nerve ablation. So LUNA, presacral neurectomy. Presacral neurectomy is done rarely, but uterine nerve ablation is done regularly. So you see, the laparoscopic, LUNA is laparoscopic uterine nerve ablation. The nerve is paying the price here. The pain is caused because of the nerves. There is hyperactivity of the sympathetic nerves. So what are they doing? Cut the nerve. LUNA, that is laparoscopic uterine nerve ablation. Laparoscopic presacral neurectomy. With this, what? The pain comes to an end. We saw in the management, first if the patient comes, give her assurance, analgesics, antispasmodic drugs, encourage her to keep the bowels empty and normal activities. If everything fails, if the patient wants pregnancy, do not give her pill, give her PSI for 3 to 6 cycles. If the patient does not want pregnancy, if she wants contraception, then you can give her pills, that also should be given for 3 to 6 cycles. Both are failing, then you go to the UST and laparoscopy should be done. We exclude the pelvic pathology. Then we move on to the nerve. Finally, there is uterine nerve ablation and presacral neurectomy. Common treatment modalities for primary dysmenorrhea. The medical management now: mefenamic acid 250 to 500 mg 8 hourly, ibuprofen 400 mg 8 hourly, naproxen 250 mg 6 hourly, COX-2 inhibitors celecoxib 200 mg twice daily. Surgical management, we already read this: laparoscopic uterine nerve ablation and laparoscopic presacral neurectomy, in which the nerve is being cut. Hormones, like the pills which were given in the want of contraception, that is combined oral contraceptive pills, that is 1 tablet daily, oral progestins D5, D25, LNG, IUS should be given. Now we move on to the secondary dysmenorrhea. Secondary dysmenorrhea is normally considered to be menstruation associated pain occurring in the presence of pelvic pathology. So whenever there is menses, there is pain. Along with the pain, there is also an associated pelvic pathology. There is some abnormality detected. Along with the abnormality, if there is pain during menses, then this is known as secondary dysmenorrhea. Secondary dysmenorrhea, the other name is congestive dysmenorrhea. Like primary dysmenorrhea was also known as spasmodic dysmenorrhea, here secondary dysmenorrhea is known as congestive dysmenorrhea. The patient profile: the patient are usually in their 30s, more often pares, that is they have offspring bed, already they have given birth to children, and unrelated to any social status. You see here, there was adolescent girls 18 to 24, but secondary dysmenorrhea along with pelvic pathology, it is found in pares women who have already given birth to children and who are in their 30s. Clinical features are: the pain is dull, situated in the back and in the front without any radiation. You can make a comparison. Here the pain is in the back and in the front, no radiation. But primary, there was radiation to the medial aspect of the thigh, and from the lower abdomen it moved to the back. It usually appears 3 to 5 days prior to the period and relieves with the start of the bleeding. There it was few hours, but here it is appearing 3 to 5 days prior. The menses have still not appeared. 3 to 5 days before to her periods, the pain is going to start, and with the start of the bleeding, the pain is going to come down. The onset and the duration of a pain depends on the pathology producing the pain. The onset as well as how long the pain is going to last. The duration of the pain, both the onset and the duration, is going to depend upon the pathology inside, depending upon the pathology which is producing the pain. There is no systemic discomfort. You saw the systemic discomforts there, like nausea, vomiting, diarrhea, fainting, all that. But here in secondary dysmenorrhea, no systemic discomfort, unlike primary dysmenorrhea. The patient have some discomfort even in between periods. So, one period to another period, the intermenstrual period, there is some discomfort found in secondary dysmenorrhea. Hope it is clear. We have also compared the primary and secondary dysmenorrhea here. Secondary dysmenorrhea only, it is found in Paris women. The pain is in the back and the front, no radiation, 3 to 5 days before the pain start, and the onset and duration depends upon the pathology, no systemic discomfort. The causes of secondary dysmenorrhea. There may be cervical stenosis. You see, stenosis is the narrowing. Cervix, cervical narrowing of the cervix, cervical stenosis, chronic pelvic infection. If there is some chronic pelvic infection, it may be a cause for secondary dysmenorrhea. Pelvic congestion, pelvic adhesions. The adhesions may be in the various forms. Adenomyosis, uterine fibroid, endometrial polyp, IUCD in utero, and pelvic congestion. We saw 2 times pelvic congestions, pelvic adhesions, adenomyosis, uterine fibroid, endometrial polyp, chronic pelvic infection, cervical stenosis. Obstruction due to the Mullerian malformation are the other causes. You see, the obstruction to the Mullerian malformation. There are Mullerian ducts. If there is a malformation in the Mullerian duct, even that could be a cause of secondary dysmenorrhea. The clinical features. There are symptoms of associated pelvic pathology. Abdominal and vaginal examinations usually reveal the offending lesions. When we do the abdominal and vaginal examination, we can find out the lesion, we can find out the abnormality in that. At times the lesion is revealed by laparoscopy, hysteroscopy or laparotomy. With these techniques, we can find out the abnormality inside the pelvic pathology either by vaginal examination and abdominal examination. If this does not help, then we also do the laparoscopy, hysteroscopy and laparotomy. Ovarian dysmenorrhea. Right ovarian vein syndrome. So every syndrome has a synonym. The ovarian dysmenorrhea is also known as right ovarian vein syndrome. Right ovarian vein crosses the ureter at right angle. You see, the vein which is supplying the ovary, it is crossing the ureter at a right angle. During the premenstrual period, due to the pelvic congestion or increased blood flow, there may be marked engorgement in the vein. When the blood flow is more, there is engorgement. Because of the pelvic congestion and also the increased blood supply, because of the increased flow, there is engorgement in the vein. Pressure on ureter. Since there is engorgement in the vein, what is it going to do? Since it is passing from the ureter, the vein is passing through the ureter, it is going to put some pressure on the ureter. Because of the pressure, there is stasis of the urine. Once there is stasis, it will lead to infection. This infection can ascend upwards into the kidneys. From the ureter, there is a connection to the kidneys. Then the kidneys might be affected and it leads to pyelonephritis and resulting in ovarian pain, ovarian dysmenorrhea, that is pain on the one side, right ovarian pain. Summarization. What happens? The right ovarian vein is going to cross the ureter at right angles. Because of it, because of the increased blood flow and also because of the pelvic congestion, there is engorgement of the vein. Since there is engorgement, it is going to put some pressure. Because of the pressure on the ureter, the urine gets stagnant there. Then it leads to infection. Infection can ascend upwards to the kidneys, cause pyelonephritis and resulting in pain. The causes of unilateral dysmenorrhea. You saw ovarian vein syndrome was one of the cause for unilateral pain. The other causes may be bicornuate uterus, unilateral location of pelvic endometriosis. If the pelvic endometriosis, if it is located on one side, small fibroid polyp near one cornua. If there is a polyp or a small fibroid in one cornua of the uterus, it can also be a cause for the unilateral dysmenorrhea. Right ovarian vein syndrome, colonic or cecal spasm. If also the intestine, colonic and the cecal spasms are also there, that could also be a pain for unilateral, that could also be a reason for unilateral dysmenorrhea. Now we move on to the Mittelschmerz syndrome. Mittelschmerz syndrome is also known as ovular pain. Like how we saw here, the ovarian dysmenorrhea is also known as right ovarian vein syndrome. In the same way, Mittelschmerz syndrome is also known as ovular pain. Ovular pain is not an infrequent complaint, which means ovular pain occurs frequently. It is found more frequently. It appears in the mid-menstrual period. When does the ovular pain occur? It occurs during the mid-menstrual period. The pain is usually situated in the hypogastrium or either iliac fossa. You see, the pain, either it is situated in the hypogastrium or the iliac fossa, either of the iliac fossa. The pain is usually located on one side. Like in the right ovarian syndrome, like how it was one-sided, in the same way, Mittelschmerz syndrome, the pain is located on one side and does not change from side to side according to which ovary is ovulating. We see in the uterus, the ovaries either cycles, each one of the ovary is going to ovulate. Since this Mittelschmerz syndrome, the pain caused by it is not going to alter from side to side irrespective of which ovary is ovulating. Nausea or vomiting is conspicuously absent. So you cannot find any systemic discomfort here. There is no nausea or vomiting. It rarely lasts more than 12 hours. It may be associated with slight vaginal bleeding or excessive mucoid vaginal discharge. So in the Mittelschmerz syndrome, the slight vaginal bleeding along with the excessive mucoidal vaginal discharge. The mucoidal discharge is more, whereas the bleeding is less. We'll summarize this. It is a ovular pain. It is a frequent complaint. When is the pain occurring? In the mid-menstrual period. The pain is found in the hypogastrium and also in the either of the iliac fossa. The pain is not going to shift from side to side. The systemic discomfort like nausea, vomiting, not found. It does not shift from side to side. No systemic discomfort. Then it lasts for more, it can rarely, at rare conditions, it lasts for more than 12 hours. It is associated with two things. One, slight vaginal bleeding. Second, excessive vaginal mucoid discharge. Causes. The exact cause is not known. Why does this Mittelschmerz syndrome occur? Why is there a slight bleeding? Why there is excessive mucoid vaginal discharge? The exact cause is not known, but the probable factors are increased tension of Graafian follicle just prior to rupture. You see, there is primary follicle, secondary follicle, which then turns into a Graafian follicle. Then the Graafian follicle gets ruptured and it gets released. Because of the increased tension of the Graafian follicle, just prior to the rupture, it might be a cause for the pain. Peritoneal irritation by the follicular fluid following ovulation. You see, the Graafian follicle ruptures and it is released into the peritoneum. Because of the menstrual syndrome, also known as premenstrual tension. Premenstrual syndrome, PMS, is a psychoneurotic endocrine disorder of unknown etiology. So, it is a psychoneurotic endocrine disorder. It's with the brain and endocrines. It is a psychoneurotic, hormones and brain, psychoneurotic endocrine disorder, but the cause is unknown. It is often associated just prior to menstruation. So, the premenstrual, the name itself signifies that it is occurring before the menses, premenstrual. It appears just prior to menstruation. There is cyclic appearance of large number of symptoms during the last 7 to 10 days of menstrual cycle. So, every cycle, the symptoms are appearing during the last 7 to 10 days. There is cyclic appearance of the symptoms during the last 7 to 10 days of menstrual cycle. It should fulfill the following criteria given by ACOG to be termed as a premenstrual syndrome. The symptoms should not be related to any organic lesion. You see, they shouldn't be related to any organic lesion. They should occur regularly during the luteal phase of each ovulatory menstrual cycle. So, the menstrual cycle has many phases like the proliferative phase, luteal phase and so on. The premenstrual cycle, the premenstrual syndrome, it should occur during the ovulatory cycle, luteal phase of ovulatory menstrual cycle. Symptoms must be severe enough to disturb the lifestyle of a woman or she requires medical help. So, the symptoms to be called under the criteria for premenstrual syndrome, PMS, the synonym, the other name is premenstrual tension. Premenstrual syndrome is a psychoneurotic endocrine disorder. So, it is dealing with the brain, the neurons and endocrine hormones. It is a psychoneurotic endocrine disorder of unknown etiology. The cause is unknown, but it is related to the psychoneurotic endocrine disorder. It is often noticed just prior to menstruation. You see the name itself, premenstrual syndrome. Premenstrual is prior to menstruation. Name itself signifies it is occurring just prior to menstruation. There is cyclic appearance of large number of symptoms during the last 7 to 10 days of menstrual cycle. So, the symptoms are appearing cyclically. Every cycle during the last 7 to 10 days, the symptoms appear. The symptoms should fulfill the following criteria given by ACOG to be termed under the premenstrual syndrome or premenstrual tension. What is the criteria given? The symptoms should not be related to any organic lesion. So, they should not have any relation with the organic lesions. They should occur regularly during the luteal phase of each ovulatory menstrual cycle. So, the menstrual cycle has different phases, proliferative, luteal and so on. The symptoms have to appear during the luteal phase of ovulatory menstrual cycle. Symptoms must be severe enough to disturb the lifestyle of a woman or she requires medicinal help. The symptoms have to be so severe that they are disturbing the day-to-day activities of a woman. Symptom-free period during the rest of the cycle. You see, from one menses to the other menses, the intermenstrual period, it should be symptom free. The intermenstrual period should be symptom free. When these symptoms disrupt the daily functioning, they are grouped under the name premenstrual dysphoric disorder. When they are hampering the day-to-day activities or disturbing the lifestyle of a woman, they are termed as premenstrual PM dysphoric disorder DD. What are the criteria, guys? 1. It should not be related to organic lesion. 2nd, it should occur regularly during the luteal phase. 3rd, it should be severe enough to disturb the day-to-day activities. When it is severe enough disturbing the day-to-day activities, it is termed as PMDD, that is premenstrual dysphoric disorder. And during the intermenstrual period, the person should be symptom-free. The pathophysiology. The exact cause is not known, but the following hypotheses are postulated. We do not know the causes, but few hypotheses have been postulated supposingly to be the cause for it. 1. There is alteration in the level of estrogen and progesterone. The estrogen and progesterone, there might be an alteration in their levels. Starting from the mid-luteal phase, either there is altered estrogen-progesterone ratio, either there might be an alteration in the estrogen-progesterone ratio, or there must be diminished progesterone level. This is a hypothesis given. The first hypothesis, they are saying if there is an alteration in the estrogen and progesterone which is released, if there is an alteration in the ratio or the progesterone level is low, it can be a cause for premenstrual syndrome. Second, Serotonin. Serotonin is an important neurotransmitter in the central nervous system. Where do we find the serotonin? It acts as a neurotransmitter in the central nervous system. During the luteal phase, the decreased synthesis of serotonin is observed. You see, during the luteal phase of ovulatory cycle, the synthesis of the serotonin is reduced in the women suffering with premenstrual syndrome. In women who are suffering with premenstrual syndrome, the synthesis of serotonin is being reduced. What is serotonin? Serotonin is nothing but a neurotransmitter in the central nervous system. First we saw there is an alteration in the estrogen-progesterone ratio. Then there may be a serotonin, decreased production of serotonin. Third, endorphins. What are endorphins? The symptom complex of premenstrual syndrome is thought to be due to the withdrawal of endorphins. Endorphins are also the neurotransmitters from the central nervous system. During the luteal phase, there is also withdrawal, which means again reduction. When there is a withdrawal of the endorphins are also the neurotransmitters released from the central nervous system. Gamma aminobutyric acid, also known as GABA, it suppresses the anxiety level in the brain. What is the action of GABA? It is suppressing the anxiety level in the brain. We saw what are all the causes. The hypothesis postulated: one, there is a alteration in the estrogen-progesterone ratio. Progesterone level can be low. Second, serotonin level is low. Endorphins level is low. Serotonin, endorphins, both are neurotransmitters. The GABA, it is also suppressing the anxiety level in the brain. Psychological and psychosocial factors. Psychological factors may be involved to produce the behavioral changes. Because of these, there might be behavioral changes in the people. The other causes might be, that is, a variety of factors have been mentioned to explain the symptom complex of PMS. Why is there a variety? Numerous symptoms are found in PMS, premenstrual syndrome. What is it? These are thyrotrophin releasing hormone, also known as TRH, the short form, thyrotrophin releasing hormone, prolactin, renin, aldosterone, prostaglandins, and others. Unfortunately, nothing is conclusive. So people postulated many theories, but then nothing came to a conclusion that this is the particular cause. We also read about the psychosocial and psychological factors which cause the behavioral changes in the person. And then in other factors might be thyrotrophin releasing hormone, prolactin, renin, aldosterone, prostaglandins, and others. Now we move on to the clinical features of premenstrual syndrome. Premenstrual syndrome is more common in women aged 30 to 45 years. So it is like in the old women, not completely aged, in the middle-aged women 30 to 45 years. It may be related to the childbirth or disturbing life event. When do the person develop premenstrual syndrome? The premenstrual syndrome, it might be related to the history of childbirth, or a disturbing life event might be present which led to the development of PMS, that is premenstrual syndrome. There are no abnormal pelvic findings expecting features of pelvic congestion. You get the laparoscopy done or USG done, you do not find any abnormality, or we cannot expect pelvic congestion. We see the clinical features of premenstrual syndrome now. Related to water retention, there is abdominal bloating, there is breast tenderness. Since there is retention of water, the abdomen can be bloated. Breast tenderness, swellings of the extremities, and since water retention, weight gain. Abdominal bloating, breast tenderness, swelling of extremities, weight gain. Now we move on to the neuropsychiatric symptoms. The neuropsychiatric symptoms are irritability, depression, mood swings, forgetfulness, restlessness, increased appetite, tearfulness, anxiety, tension, confusion, headache, anger. You see, so many psychiatric symptoms are found. Neuropsychiatric symptoms are irritability, depression, mood swings, forgetfulness, restlessness. Increased appetite is found in these people. Tearfulness, anxiety, tension, confusion, headache, and anger. Behavioral symptoms: fatigue, dyspareunia, that is painful coitus or painful sexual intercourse, tiredness, insomnia, that is sleeplessness, person does not get sleep. Thank you. With this, we come to an end of the chapter, Dysmenorrhea and Disorders of Menstrual Cycle. If you like my video, hit the like button and subscribe.